Hello, everyone, and welcome back from lunch. I hope you're rested and satiated. Welcome to session 3 of this year's symposium. My name is Ben Wills. I'm a senior project manager and research assistant at the Hastings Center, and I'll be moderating this third session. This session, session 3, focuses on the impacts on prospective parents and their sense of responsibility associated with receiving genetic risk information about their fetuses. And I am delighted to be moderating a panel with two excellent speakers. The first is Stina, who is an anthropologist and senior social scientist at Aarhus University Hospital in Denmark. And the discussant is Kimberly Mutcherson, who is co-dean and professor of law at Rutgers Law School in Camden. She writes on issues related to reproductive justice with a focus on assisted reproduction, abortion, and maternal fetal decision-making. Stina, over to you.
Thank you. I think I need to work on my bio. That's one thing I've learned. And thank you for the invitation to speak this symposium. I'm quite honored to be in this panel with these people. And this is definitely not my usual audience. So I hope we can have a fruitful interdisciplinary talk after I have found my slides. There. You see them okay?
Yes, thank you.
Okay, hang on. Okay, so I'm a non-native speaker and I tend to get a little bit nervous. So I have written an incomplete manuscript, okay? So bear with me for this. I will present myself shortly, but first I want to say that the title of this presentation gave me more headaches than expected. And I had to add that little extra title, as you can see. The organizers asked me to specifically focus on responsibilities related to a prenatal diagnosis of Down syndrome. And as preparation, I reread the work of anthropologist Raina Repp and other great scholars in this field. Back in the 90s, Raina Repp made a seminal analysis of the meaning of amniocentesis in America. Her work provides a complex and sensitive insight into women's reproductive decision-making in face of a prenatal diagnosis. And I thought, in the academic context of this symposium, and with all the work that's been done on Down syndrome, what can I possibly add? Hasn't everything already been said? Is the topic of women's responsibility in pregnancy not exhausted? Because it has been well argued by Raina Repp and others that pregnant women who receive a prenatal diagnosis must navigate at least two competing responsibilities. On one hand, women are expected to be responsible and loving mothers from conception, or even from the moment when they start contemplating pregnancy. A responsible mother makes it her main priority to create a safe and nourishing environment for the baby in the belly. This includes the willpower to forsake own desires in order to ensure the best possible start for the baby. No more fatty French cheeses or red wine, okay? On the other hand, are pregnant women also expected to act as responsible citizens in face of diagnosis? They are expected to terminate the pregnancy if the baby is unhealthy and unlikely to become a productive citizen of the nation state. In this double bind, pregnant women are positioned as moral pioneers. They guard the borders of the human community and decide who gets to join. At an individual level, pregnant women are delegated responsibility for judging what it takes, what qualities are needed in order to enter the world of the human. More than 20 years after Testing Women were first published, prenatal screening has become the norm in most healthcare systems. Pregnant women are systematically and routinely offered to have their fetuses monitored and assessed, and the amount and detail of such knowledge is ever increasing. In most countries, the offer of genetic screening for Down syndrome and other chromosomal abnormalities is grounded in a premise of non-directive information and autonomous choice. So the healthcare system delivers neutral information about the fetus and the woman makes her reproductive choice. This has, of course, been done to distance the offer of prenatal screening from the historical ghosts of centralized state eugenics. However, the outcome is strikingly similar due to the cumulative effect of pregnant women's preferences for abortion in the case of Down syndrome. These personal preferences are, of course, deeply embedded in particular social, political, cultural, historical contexts. And as such, they can be understood as a postmodern form of internalized social control, a biological self-discipline as formulated by Novus and Rose. And these insights are really important, and I think that no one will disagree. But I have to say that my everyday life is very different. I work in a hospital where prospective parents get bad news and where clinicians strive to do the best good for the individual couple in a situation that is inherently difficult. And that is what I want to talk about today. So hi, my name is Stina. I am an anthropologist with a PhD in medicine in prenatal screening. For the past 10 years, I have primarily done research within prenatal diagnosis, fetal medicine, ambiguous results, and decision-making. I work as a senior social scientist at the Interdisciplinary Center for Fetal Diagnostics at Aarhus University Hospital in Denmark, which is the second largest hospital in Denmark. So I work and do research with fetal medicine specialists, geneticists, obstetricians, and midwives, and my main motivation is to make a difference in the clinic. For example, regarding the case of a prenatal diagnosis for Down syndrome. Cheers. Prospective parents who've been in that situation often describe the moment where the doctor says Down syndrome as a shock, a blackout, or as getting tunnel vision. One woman described it like this: I never imagined it would happen to me. When they called, I was devastated, hyperventilating, and crying. I cried so much. I was so upset. Because you have this image of the baby in your belly, what it will be like. And then it just wasn't like that at all. So there was that grief, letting go of a child that you're not going to have anyway. A prenatal diagnosis accelerates time as desired futures must be reimagined. And it narrows down all the infinite uncertainties of human life to one issue: Down syndrome. In this presentation, I will share with you how people navigate to find a meaningful way through this tunnel towards either termination or continuation of pregnancy. I will show how situated and relational responsibilities are enacted in that process. And I will finish off by showing some of the ways these quote unquote patient perspectives have made a difference for clinical practice. In Denmark, in 2004, Denmark was one of the first countries to introduce a uniform and comprehensive prenatal screening program for all pregnant women. As with all healthcare in Denmark, the program is free of charge. Among other things, it includes a 12-week ultrasound scan and the option of a risk assessment for chromosomal aberrations, including Down syndrome. Participation is based on informed choice, and the stated aim of the program is, should a woman want to participate, to provide information that allows the woman to make an autonomous reproductive choice in accordance with her own values. The program has a very high uptake, and when Down syndrome is diagnosed, the vast majority will choose to terminate. In Denmark, abortion is a woman's legal right up to and including 12th gestational week, and allowed upon approval by a specialist board up to and including 22 gestational weeks. If you're interested in knowing more about the Danish context, I can highly recommend this article by Sarah Sang, who really thoroughly and thoughtfully considers the case of Down syndrome in the December issue of The Atlantic. One of the things that both Sarah and I are curious about is how Danish women's reproductive choices means that every year only a handful of prenatally diagnosed children with Down syndrome are born. So out of approximately 180 fetuses diagnosed during pregnancy in 2019, only 7 were allowed to cross the borders into the human community and were actually born. And as a society in Denmark, we remain rather uneasy about that. Yeah, so I know a few of you will be a little challenged on the language here, but these media headlines read death to Downs. There are a few like Elliot left, and the doctors tried to persuade us to terminate. In these media stories, the systematic deselection of fetuses with Down syndrome is usually blamed on the women who are probably not knowledgeable enough, or on the doctors who are probably really biased in their information. But the women who have terminated, they remain absolutely quiet in these debates. They are the silent majority, and we needed to hear their voices. We were curious about what had informed the decision and how they might have felt pressure from clinicians to terminate. So I interviewed 21 women and 11 partners who had just recently been in that situation. In the interviews, some couples described how they had openly discussed their values regarding disability and prenatal diagnosis, and this is going to sound harsh, but neither of us wanted to have a child with Down syndrome. Others made the decision in more subtle ways. Lene, who is the mother of 2 young boys, said, "We never really articulated it, but we had a silent understanding that if we were expecting a sick or disabled child, then we would terminate the pregnancy." So you do have some kind of common understanding deep inside, but we had not explicitly discussed it. I think Lene's quote is interesting because it challenges the screening program's internal logic of choice, which is based on the assumption that good and responsible decisions are based on thorough contemplation of available evidence. So has Lene and her husband made an informed choice? Can we accept instinct and gut feelings and silent understandings? Maybe we can discuss this. My point is that the majority of these couples entered the screening program with an implicit or explicit intention to terminate in case something was wrong. But why? Why don't Danish women want children with Down syndrome? When asking the couples to put into words what shaped the decision to terminate, relational responsibilities towards the child, towards potential siblings, and the family as a whole were dominant. The decision was driven by care and concern for the future child, and the couples emphasized that it would not have the same opportunities as other children, would need lifelong special needs support, and maybe even institutionalization. Others expressed deep concern about additional diagnoses, such as autism. The prospective parents wanted to protect the future child from such harms. "Life is hard enough as it is," one said. "You don't have a child to put it in an institution," another one said. Emotional responsibilities towards current or future siblings were often highlighted as the parents worried about the siblings suffering from being second priority in a family with a disabled child. Furthermore, it was articulated as unfair that siblings would involuntarily be assigned a lifelong responsibility for their Down syndrome brother or sister. Finally, responsibilities towards keeping the family together were often stressed, and in statements such as, "I'm not sure our marriage would last. It's a lot of pressure to care and worry for a disabled child." Thus, being responsible for the future welfare of family members, including the fetus, was an important driver of the decision. One mother said, "I choose to focus on our life and on what we want from our future life. And with that in mind, we have no doubts at all." So some of you in the audience might think to yourselves, wow, that's a pretty negative and one-sided understanding of Down syndrome. Children in institutions, burden on siblings, broken marriages. And you're right, I'll get back to that. And now I will also say that even though the couples felt certain about this decision to terminate, it was still emotionally demanding. Maria says, I've told it that I'm sorry. I said sorry again just before the surgery. I was lying on that hospital bed thinking, oh, you didn't even get a chance to show us who you are. But I'm really hoping that I'm doing the best for all of us. I'm hoping that I also spare him some pain. I have to hope for that. But there's some kind of, I wouldn't call it guilt, but there's something unnatural about it. You walk through the door as a mother with a baby in your belly. And even though I know that it would be disabled and has Down syndrome, ending it is just a bit unnatural. I wouldn't call it wrong because I don't think it is, and I can fully justify why I did it, but still. Like Maria, all couples reflected on the burden of being responsible for choosing to end a pregnancy which they had deeply desired. And 3 issues emerged. Uncertainty of phenotype. During interviews, many couples actually expressed pretty detailed factual knowledge about Down syndrome and the potential diversity of the Down phenotype. When reflecting on their decision to terminate, they often focused on what we could call a worst-case scenario: children in institutions, burden on siblings, broken marriages. However, all couples raised the point that people with Down syndrome can lead fulfilling lives and be valuable and valued members of a family. This is my friend Karina and her sweet daughter Emmy proving just that. Thus, the couples were painfully aware that they had decided to terminate what could also be a potentially good and happy life. I love this picture. Several women longed for a crystal ball, and one woman said, if I could only see the future, if I could only have seen him at the age of 8, that he was okay, then maybe I could have had the courage to continue. Maybe. Being responsible for the decision to terminate included fear of future regret. At the time of the interview, none had regretted, but one woman who had struggled with infertility and repeated miscarriages said, I worry if this was my chance. I worry that 5 years from now, we still don't have a child, and this was my chance to have a baby. Then I will forever regret this decision we've made. Finally, all acknowledged the burden of choice and having decided to end a potential life. So it's weighing on me because it was my choice, or it was our choice not to have it, and we have to live with that. Several participants spoke of the moral weight of being the master of life and death. And many women mentioned having momentarily dreamt of non-choice, in which responsibility for decision-making could be out of their hands. For example, a spontaneous miscarriage, or giving birth to an undiagnosed baby. One woman said, you know, had the risk been normal and we had gotten a child with Down syndrome anyway, you know, that happens sometimes, then of course we would have loved it endlessly and fought for it nail and claw. That being said, it's important to state that these women and partners felt grateful for having access to testing and for knowing about the diagnosis, despite the grief and sadness that followed in its wake. Before we move on to the parents who decide to continue pregnancy, I want to share some of Gry's story with you. And Gry is actually a woman's name in Denmark, and I invite you all to try to pronounce it. I don't know why I didn't give her more English-friendly synonym, but now she's Gry, and I can't call her anything else. On paper, she is the poster girl for informed decision-making, but her case also serves to illustrate the limits of information. Gry is married to Morten and both work in insurance. They are parents of 2 young boys, and Gry explained to me how she always had a soft spot for people with Down syndrome, and how she'd always considered their family to be the type of family who could easily include and welcome a child with Down syndrome. However, as this hypothetical situation becomes a real and inescapable situation of choice, she feels less certain. In order to make a decision, she turns to a range of knowledge sources to figure out what to do. And you can see a list of some of them here. As these different experts share their knowledge about a life with Down syndrome, Gry comes to realize that they can tell her about a range of experiences, and they can highlight potential futures, but they cannot give her the desired information about the child in her belly. Despite all the positive stories about life with Down syndrome, the risk of the worst case scenario tips the decision. Gry says, there are so many things that you can't see, and those are the difficult, the worst ones, like the level of cognitive disability and maybe psychiatric disorders. We talked about that. We have to take the full spectrum of outcomes into account and say that even if we end up with the worst case scenario, then that would be acceptable. But we can't say that. When dealing with probabilities, many of us tend to focus on the worst possible outcome and behave as to minimize the loss associated with it. Children in institutions, burden on siblings, broken marriages. Despite her initial intention on focusing on the possibilities and potentialities of Down syndrome, the uncertainty becomes too much. How should we as clinicians and healthcare systems support Gry? Did we undermine her initial values with our statistics and biomedical focus? Among the 21 women interviewed, 3 had felt an initial uncertainty about their decision, but all of them reported the risk of the worst case scenario as essentially defining the decision to terminate. We have pointed out that these women may need a bit extra support as they come to terms with the loss of the baby and with a change in their self-perception as a mother who would welcome a baby with Down syndrome. Despite standing by the decision to terminate, many couples worried about stigma and judgment from others. They considered the decision a private matter and often chose to speak of it in terms of a loss or a sick fetus to avoid discussions. Interestingly, none of them had experienced negative comments, and some even had support from unexpected places. We have many friends at church, and I was worried about their reaction. But one of my friends, she said, my husband and I have talked about it, and we would have made the same choice. And I was like, thank you for telling me this, because I really needed someone saying something like that. Standing at the crossroads of a Down syndrome diagnosis, some prospective parents decide to continue pregnancy. In 2019, it was 7. We were curious to learn more about their perspectives and learn how we support continuation of pregnancy as a real and legitimate reproductive choice. So we interviewed 8 mothers and 5 fathers of children with Down syndrome that had been diagnosed during pregnancy. These parents expressed a deep and immediate sense of connection and parental responsibility towards the fetus, particularly from the moment they saw it on the ultrasound screen. All described how the uncertainty about their child's health made them feel more caring and more protective towards the pregnancy. I felt like I was a safeguard, that there was this vulnerable child growing inside me, or not vulnerable, but someone who really needed me. So my first thought was, well, I'll just take extra special care of her then. And one woman who had struggled with infertility said, finally, there was life in there, and I was going to protect it. The parents generally emphasized an acceptance and readiness for the uncertainties of life. Life is unpredictable and it doesn't come with guarantees. Often they stressed that many unexpected things can happen in a child's or a family's life, and that Down syndrome is not the worst. I've seen kids a lot worse than Down syndrome. Autism, severe physical disability, that's worse. Some syndromes are really horrible, you know, like constant fractures or peeling off skin. That stuff you see on TV. It doesn't hurt to have Down syndrome. I mean, it's not a life of suffering. All parents had concerns regarding their child's future when making the decision to continue. the cognitive development, potential additional diagnoses, future life options. They worried about acceptance from social networks and from society as a whole. They worried about who would care for their adult child in the future. During decision making, they were also concerned that siblings would feel burdened by having a Down syndrome brother or sister. However, their main focus was actually on how a sibling with Down syndrome could add to their family in terms of teaching patience and empathy, and for generating joy and happiness. These parents had exactly the same considerations as the couples who chose to terminate, but they arrived at a different conclusion and seemed more willing to embrace the potentialities rather than uncertainties and to focus on the best case scenario. However, several parents were critical of the notion choosing to continue and emphasized how they had not actively chosen or hoped for a child with Down syndrome. In all of this, I think it's just really important to make clear that that part about choosing a child with Down syndrome, I feel a little provoked by that, because yes, we chose to keep our baby, yes, but we didn't choose for her to be disabled. It was not our decision that she has Down syndrome. All we chose was to keep the child that came, the child that we were given. And it may surprise you, but this perspective has been such an eye-opener in the clinic. Prospective parents pregnant with a Down syndrome baby should be understood and approached in the clinic as accepting responsibility for a child that is already there. Their situation is no different than parents receiving a postnatal diagnosis. We know that parents who learn about their child's syndrome after birth focus on their hopes for the future and the potential of a best case scenario. It's important coping mechanisms for them. So at the fetal medicine unit and the obstetrics department, we should support prospective parents in exactly this process rather than constantly focusing on potential medical problems. And like the parents who terminate, these parents also express fear of stigma for being judged for making an irresponsible decision. Just knowing that most would have terminated and here we are continuing, sometimes I thought, why? Do we have it all wrong? And another one says, so in a way, you're quite lonely in that decision. And I did think, maybe there's something wrong with me since I just don't do what 98% of all people would do. The aim of this research was to inform clinical practice. In the ultrasound examination room and the genetics consultations, clinicians are positioned right alongside the prospective parents at the frontiers of humanity and dealing with the ambivalences, dilemmas, and conflicts of prenatal diagnosis as a part of their daily work. With this work, they now have access to experiential knowledge and a range of narratives that can be shared with parents in similar situations. During this work, we have discussed how important decisions are not only based on biomedical information, and that more information is not always the solution. Sometimes we should point towards the psychologists or the hospital chaplains and be more appreciative of gut feelings and instincts. We've discussed the importance of sometimes slowing down. Prospective parents will sometimes make hasty decisions in order to quickly escape an uncomfortable situation. But as professionals, we can give them time to consolidate the decision. And we can legitimize grief. For those who continue, we must have tolerance for the parents' right to focus on the potential best case scenario and all that is completely normal in a pregnancy where the baby just happens to have Down syndrome. And we have a role to play for those parents who decide to take the road less traveled. For the past 20 years, we've seen a massive increase in prenatal screening and the information available about the unborn child. At Center for Fetal Diagnostics, we are currently conducting research on prenatal results that show genetic variations of uncertain significance, and we are investigating prospective parents' response to a trisomy 16 mosaicism in pregnancy. Findings that are much more unknowable, uncertain, and unpredictable than Down syndrome. So the topic of pregnant women's responsibilities in pregnancy are far from exhausted, but I do think it's striking that the weight of being the moral pioneer, being the guardian of the borders of humanity, is every bit as complex, ambiguous, and as important today as it was more than 20 years ago when Raina wrote, "Testing Women, Testing the Fetus." Thank you very much.
Thank you very much, Stina. Kim, up to you.
All right, so I'm unmuted and I've started my video, although I can't see myself, but I'm going to assume that folks can at least hear me here. I'm also going to start my timer. I respect that Stina did such a good time staying on pace, so I'm going to try to do the same here. One, I want to thank the conference organizers for inviting me to participate in this event, and I really want to thank Stina for allowing me to engage with her work, which I think is incredibly interesting and is right in my wheelhouse. I've been writing and teaching and speaking about issues related to procreation, pregnancy, and parenting for a lot of years, and I use law and bioethics to have those conversations. In fact, I teach a course at my law school called Bioethics, Babies, and Baby Making, where we cover everything from abortion to prenatal and pre-implantation testing, forced C-sections, incarcerating pregnant women for using illicit drugs during pregnancy, decision-making for dying children, right? All of these incredibly tough issues that are inherent in deciding whether to bring a new person into the world. And I like the lens of bioethics because it allows me to be a lot more nuanced in conversations, right? Law tends to be a very blunt instrument, and bioethics allows what I think to be a more robust conversation. There are a few categories of responses that I have to the issue of prenatal testing and Down syndrome or any sort of disability. But before I get into the specifics, I want to be really clear about the lens through which I think about, talk about, teach about, and write about these issues. I am fundamentally a reproductive justice scholar. And while the term reproductive justice gets thrown around a fair amount these days, I think it's really important to be clear about its origins and its relevance to the work that I do. So if you'll please indulge me for a minute, just so I can make sure that we're all on the same page. So reproductive justice is a movement that was begun by Black women in the United States in the mid-90s as a corrective to mainstream women's rights movements, which were typically led by upper middle class white women, and also tended to have a focus on abortion to the exclusion of a range of other issues that were pertinent to communities of color and low income communities. So the framework of reproductive justice refers to a woman's human right to decide if and when she'll have a baby and the conditions under which she'll give birth, to decide if she won't have a baby and her options for preventing or ending a pregnancy, and to parent the children she already has with the necessary social supports in safe environments and healthy communities, and without the fear of violence from individuals or the government. So the reproductive justice framework is a much more fulsome framework than the sort of typical reproductive rights framework. It is human rights based, it is intersectional, meaning that it recognizes that multiple marginalized identities have specific meaning in the reproductive oppression that people experience. It is rooted in the experiences of women of color and communities of color, and absolutely recognizes that reproductive oppression is experienced differently across communities of color and other marginalized communities. And so my work basically draws two basic principles from the RJ framework. One, that having a baby and being able to parent a child is as important as being able to avoid pregnancy in the first instance or to terminate a pregnancy. And second, that sex, procreation, parenting, and family are treated in a range of disparate ways along several axes, including race, class, gender, immigration status, histories of incarceration, sexual orientation, age, and more. So before I jump into the specifics of my response, I also want to just offer 2 points. One, I will mostly be using the term women to refer to pregnant decision makers that I'm talking about. And I am doing that with full knowledge that trans men and non-binary people are capable of and sometimes choose to pursue pregnancy. But I think it's very important in this context to take account of the gendered nature of how pregnancy has been studied, understood, and regulated over time, and the impact that has had on the lived experiences of a very wide spectrum of women. And second, though I work in bioethics, the law part is very predominant in me. So I'm always really interested in what theory means in practical terms, which is part of what I find so moving about Stina's work. My comments are going to be grounded in thinking about what any of what we're discussing means for real people who are making real decisions that will impact their own lives and the lives of others. So let me get into my responses to Stina's work. And to be fair, I will say that Stina was also kind enough to send me the Atlantic piece, which I also had an opportunity to read. So I'm responding to both of those here. I appreciate that Stina's work comes from a very specific place in terms of the country and culture that she's writing about. And I think it's actually very critical to note that location, culture, and identity are issues that matter when we talk about responsibility and when we talk about choice. So first, I want to emphasize the absolutely obvious point that choice is always exercised within the context of constraints, and the roots of those constraints are critical to our understanding of how people exercise their choices. So to talk about women in some generic sense in this discussion about responsibility and choices made during pregnancy is to lose really critical context. So for instance, a white woman who is married to a man and lives in a country where she has access to prenatal care, particularly free prenatal care, and potentially a wealth of services post-birth if she gives birth to a child who is living with Down syndrome, is making that decision within a very different environment than lots of other women. For instance, what about low-income women who have less access to prenatal care, or undocumented women who are afraid of getting prenatal care, or women who use illegal substances and who also fear getting care because they might be tested and arrested and their children taken from them because of their substance use disorder? What about women whose pregnancy decisions subject them to welfare caps in the United States, meaning that if they have another child, they will not receive more public support to help take care, financial support to help care for that child? What about women who are unpartnered in a country where childcare is woefully expensive? Women get paid less than men, and women of color get paid less than white women. What about women who have to think of intersecting marginalized identities for their future child? So for instance, a child who is living with Down syndrome, who is a person of color, and who is also low income. Women are not a monolith. And of course, not all pregnant people are women, as I said. So we need to think really carefully about the implications of choice rhetoric for a wide range of women, not just those who possess various kinds of privilege. And in conjunction with this understanding of choice is an understanding that when we talk about autonomous choices, we should be clear about what kind of autonomy we're referencing. And we heard this in Stina's presentation. Given what I've already said about choice, it's probably obvious that my work focuses on autonomy as a relational concept, not in a sort of rigid traditional sense, which also impacts the framework through which women make these choices. I also want to focus on the word responsibility, which has specific implications in this context, especially in a country like the United States, where we've seen personal responsibility used in incredibly pernicious ways to demonize communities of color, especially Black communities. And here I mean responsibility in the sense of accountability and blame. One of the most prominent examples of this, of course, is the welfare reform movement of the 1990s. Where there was no discussion of systemic racism and systemic issues that lead to poverty. And instead, the rhetoric was about how individual decisions, right, the failure to take responsibility for yourself or be responsible was the root of income inequality in this country, which is obviously a deeply flawed analysis, but one with a very strong political pull. So in this sense, the level of agency that responsibility implies is significant. And going back to what I just said about choice, it fails to encompass the lived realities of people who are making reproductive decisions in a world filled with reproductive hierarchies and with judgment. And of course, as Stina's work suggests, and as we all know, it's critical to take account of the gendered nature of responsibility in this context. Even for folks who are partnered with men, the ultimate consent for testing and abortion needs to come from the person who is pregnant, so that women bear this burden and do so again with the weight of the intersectional implications of womanhood. Certainly in the United States, and that's the milieu that I can talk about with the most authority, it has long been the case that motherhood is valorized for some, especially for married white women whose husbands work outside the home while their wives take on the role of caregiver, and denigrated for others. So think of the myth of the welfare queen in the United States, which is always a poor Black woman having baby after baby in order to take more money from the state. And also think about the history of sterilization abuse in the United States and its targeting of women of color and low-income women. So given this reality, it's not clear that there is some socially responsible choice for women to make about giving birth to a child who will have Down syndrome or who will be living with a disability, and certainly not a socially responsible choice that will be the same across women with different identity categories. So this conversation also pulls me to think about the currently popular anti-choice rhetoric that lumps in disability bans and race-based bans on abortion. So on one hand, obviously, this is just a strategic move, but it also reinforces notions of good and bad motherhood. And as well, the idea that motherhood begins the moment that one thinks about pregnancy, or certainly the moment that conception happens. And so bad mothers are those who opt for abortion because they don't want to raise a child who shares their racial identity, or because they don't value the lives of people with disabilities. I think in particular of the Billboard campaign that was happening in the United States not too long ago, where the slogan on these billboards was, "The most dangerous place for an African American is in the womb." So really judging Black women as being an actual risk to their own community by virtue of the fact that they were exercising their ability to terminate pregnancies. And so I want to end with a conversation about responsibility and selfishness. I'm always struck by the women who express concern that they'll be judged as selfish for opting to terminate a pregnancy because they don't wish to raise a child who is living with Down syndrome or another disability. So even if, as Stina's work shows, people focus on the worst case scenario when they are making their abortion decisions in this context, the concern of being considered selfish is a theme that's heard in lots of other contexts when it comes to abortion decisions. And to the extent that what underlies some of this discussion about selfishness is really steeped in these normative ideas about what it means to be a mother, or what mothers owe to children, as opposed to what fathers owe to children. As a starting point, I take the position that having children at all is a selfish act. And I say that as a parent of 2 children. No child asks to be born. Those are the decisions that we make. But we should also be careful about using skewed notions of gender obligations to evaluate decision-making in this space. So I want to make a bunch of propositions here that perhaps people will agree on, but perhaps not. And certainly we can talk about that in the Q&A. First, women are not bound to become mothers. Women who become mothers aren't bound to enjoy motherhood. Women who enjoy motherhood aren't bound to subsume their own life's plans, including plans that may be impacted by having a child whose needs are greater than anticipated. Taking care of any child is a burden, even if a chosen or welcome burden, regardless of whether that child has Down syndrome or autism or diabetes or sickle cell anemia. I appreciate that the disability critique of testing, at least the people whose work I teach, is explicitly pro-choice and recognizes that women can choose a life path, including choosing whether that path will include children at all or will include specific children. I also appreciate the need to think critically about how people, especially women, experience responsibility when making these decisions and the importance of accurate information and appropriate counseling and space while they're making those decisions. But I want to be sure that the critical lens that we use in this context is an intersectional one that understands women within a context and within their individualized identities in webs of connection. And then I want to just make one really quick point that might be worth talking about in the Q&A, which is whether we think about responsibility and choices and decision-making differently before pregnancy even begins. So a lot of my work is in assisted reproduction, and there we have situations where people are making decisions about what embryos to use, what embryos to discard after they have been tested. And do we think about responsibility differently for people who have the resources and the wherewithal to use that kind of testing, which also suggests that they have the resources and the wherewithal to care for a child who may have significant needs. And I'll stop there.
Thank you so much, Kim. That was really wonderful. Stina, do you want to take a moment to respond?
I will just say that I think it was really wonderful too, and I agree. And I think the problem, it's not a problem, but Denmark is just like this little crazy country where we have this welfare system and 1 year's paid maternity leave, and we are assisted in every way. And I think that was also Sarah Sang's curiosity about Denmark and Down syndrome, was that, I mean, if you are going to have a child with Down syndrome, Denmark is the place. So why not? Yeah.
Great. While we are waiting for some more attendees to put some questions, to raise their hands and put some questions in the chat, we have a comment from Ellen Wright. And Ellen's just raised her hand. So Ellen, I'm going to allow you to talk if you would like to unmute yourself and elaborate on that.
Oh, great. Well, first of all, my name is Ellen Clayton, so you have it wrong up there. But I was so struck listening to you talk, Stina, because the situation that you address is radically different from what exists here. I mean, more than half of women in the United States don't have access to prenatal diagnosis, even if they want it. We have 2 states, one of which I live in, that now forbids abortion after prenatal diagnosis and makes the physician who does that procedure a felon. So with prison time, it's really quite remarkable. And the other thing is that we actually, but the more important thing is that many, many women in this country choose to proceed with pregnancy, even following prenatal diagnosis. And I teach at Vanderbilt, where children with prenatal diagnosis actually go to a program called Next Steps, which is actually college for kids with Down syndrome. I mean, so the situation has changed quite a bit in this country. I do think that, but I also acknowledge, as Kim says, that despite greater facilities available now in this country, the fact of the matter is, it's just hard. And if women, I think after they're informed, have the right to make their own choice. Or I have asserted for more than 40 years that they have the right to make that choice. Maybe not, but I'm really delighted to hear you present your work, Stina. I've heard a lot about your article. But frankly, the way I see it in the United States is that we're in an absolutely terrifying time. And prenatal diagnosis is actually not going to have much utility in many parts of the country.
Thank you.
If I could just, oh, sorry.
Oh, can I make one other thing? We also do research on how parents who have a child with a diagnosis of a congenital anomaly do once they get the diagnosis and make the decision to proceed. And boy, it's tough. It's really tough. We've looked at complex congenital heart disease, which of course includes Down syndrome. And it's that it is, and the evidence suggests that prenatal diagnosis of those actually leads to long-term anxiety for parents, longer term than discovering this at birth. So it's a complex situation here in the United States, getting more complex. So sorry, I'll be quiet now.
Go for it, either one of you.
Okay. So I just wanted to respond to the law piece of what Ellen put on the table. So we are obviously in a period of transition in the United States. And the kinds of bans that we are seeing now on access to abortion, whether they're disability bans or race-based bans, are all being challenged in court. What's going to happen when they reach the Supreme Court, I can't particularly tell you, but it is certainly the case that those kinds of bans raise significant constitutional issues that even this Supreme Court might decide remain unconstitutional. The other thing that I want to say, though, is towards the end of her talk, Stina was talking about, who were the people who parents or decision makers might want or need to talk to before deciding whether they're going to terminate a pregnancy that involves a child who will be a child living with Down syndrome. And I want to really reinforce, again, sort of thinking in this holistic way about the many different women who become pregnant and who might have to make these decisions, that even a conversation with a counselor might not be the right conversation, right? So Stina talked about a chaplain, but also just the kind of cultural competency that is required in order to understand the context in which someone is engaging in decision-making is so critical.
Yeah, I think it's really important that we I think it's a problem. The autonomous choice ideology is a problem, and it's also a problem for doctors because it limits them in their communication with women and couples. I think we need to figure out, and we're talking about this, and how do we incorporate other ways of knowing and make it legitimate to have like a gut feeling or a spiritual belief, or and that women can make legitimate decisions based on other things than biomedical information. But doctors are not used to speaking about these things, so it can be difficult to include in a clinical conversation.
Great. An anonymous attendee notes, regarding the idea that the child has no say in being born, that is all the decision of the parents to bring a child into the world. In some cultures, the child is a soul before a being, and indeed that soul wants to join the world and has some role in their own development, even before being conceived. When we were talking about public health impacts, we need to recognize and acknowledge other ethnicities and native beliefs. Kim and Stina, your reflections on that?
I think I'm doing a study on women who free birth, who choose to birth outside the system without the aid of a professional, and many of them have these views that that it's a collaboration, that getting pregnant and giving birth is a collaboration between the mother and the child, and it's actually quite powerful because it also means that she can give birth at home. And the outcome of the birth is not her responsibility alone. It's something that she shares with the baby and the baby's spirit. So I'm actually quite inspired by that. And I think we can learn a lot from being open to some of these perspectives.
I guess what I would say, wearing my law hat a little bit. So first of all, yes, right, that in the context of the clinical setting, cultural competency is critical, right? So people understand who they're talking to and the beliefs that that person is bringing to the table. My law hat says that the extent to which we extend fetal personhood is problematic for our ability to also say who gets to make decisions about whether a pregnancy continues or does not. And so I understand that cultural context, but I also understand the ways in which that clashes with, a belief that the person who gets to make decisions about that pregnancy is the person who is pregnant and already in the world.
Very important point.
Great. I had a question for Stina. I think a lot of folks in the audience probably came to know your work through the Atlantic article, which seemed really great to many of my colleagues. And so I was wondering how you kind of perceive that, if you could speak to that a little bit more, and if and how that changed the conversation in the context in which you work.
It was, I think it was the first time that we felt that we truly had a journalist represent a nuanced picture of what is going on. The Atlantic feature is quite a difficult read for most Danes. So it hasn't really been read as widely as I would have liked. And also I don't think the Down Syndrome Association has done a whole lot to promote it. So it's not as known in Denmark as I would have liked. But I will also say that I was not sure if I wanted Denmark to know about that feature until I read it. Because sometimes I spent a whole day with Sarah and we had a really wonderful conversation, but sometimes it ends up with the doctor tried to persuade us to terminate headline. So she was sending me my quotes and I was thinking, yeah, it's okay. But then they were fact checking, you know, the number of people who had been forced to being sterilized, for example. And I thought, oh, I wonder where this is going. So I hope that it can maybe have more impact. And I think it's a really useful article. But for a Dane, it's difficult to read.
That's great. Yeah, I really appreciated the way that kind of captured what I perceived to be kind of the complications of the welfare state, right? Because the US has, I mean, in the journalism that I read, it's pretty kind of just monotonically positive of, you know, every Scandinavian and near Scandinavian welfare country. So I really appreciated the way it kind of complicated our imagination of what it's like up there. Just to follow up on that, do you have a sense of if kind of that dynamic that Zhang speaks about is specific to Denmark, or do you think that that is similar in your kind of neighboring countries?
And what dynamic? I just have to make sure I understand.
I just mean the kind of the tensions that Zhang is talking about, which seem to be kind of, you know, speaking about kind of the tensions of engaging with this, where there's, you know, great access to prenatal care, and then kind of what does informed consent look like in that context, especially if people have a strong sense of social cohesion and perhaps some responsibility to, you know, promoting the welfare and benefit of their kind of community, the national community as a whole. Do you have a sense in talking to your colleagues in Europe and any research that you've done, if that is similar in other countries, if there's kind of particularities of Denmark's history and kind of where it is now that make it kind of unique in that way?
I know mostly about the Swedish community, and they have the same issues. Also, this sort of societal uneasiness about the number of women who choose to terminate. We think that we are inclusive countries, so we should actually be able to nurture environments where people can give birth to children that are not perfect. And so we feel uncomfortable with that it's not the case. In Norway, they have only recently gotten access, and I don't even know if it's implemented fully yet, to prenatal screening. Norway has not allowed screening of pregnant women for Down syndrome unless they were over the age of 35. So it's always interesting to discuss with the Norwegians because their situation has been quite different.
Mm-hmm.
Could I say one more thing? I don't know where we are in terms of time.
Yeah, please, Kim, why don't you take the last word and then we'll wrap up.
So the thing that I wanted to add, I mean, I think sort of what's important about thinking about these different contexts is that, you know, in a place where you do have access to resources, and particularly where you don't have to pay for those things, the fact that you still have this very high rate of termination, I think is a really important thing for us to be focused on and trying to understand where that's coming from. And I think a piece of that you know, still comes from the way that lots of people think about disability and how we think about bodies and how we think about whether folks are neurotypical. And I can certainly say for myself, and this has been my experience in teaching as well, I've been teaching my bioethics course for, over 15 years now. And the thing that has been most critical to me in terms of literally changing the way I view the world is really engaging with the disability critique of all of these things, right? And understanding disability is socially constructed. And there's still a lot of work to be done to help people think about, to reframe how we think about disability in all of our, I think in all of our societies, or certainly many of our societies. And that would have a different sort of impact on decision-making than just available resources.
Great. Well, on that note, thank you both very much for a fantastic and fascinating panel. And I will hand it off to Lucas Matthews, who will run session 4.